Good evening, friends. Today is 4th of March 2022, and today is the World Obesity Day. Obesity Day has a theme today to act. Everybody needs to act. We can all work together to ensure happier, healthier, and longer lives for everybody. 800 million people around the world are living with obesity. The medical consequences of obesity will cost over $1 trillion by 2025. People living with obesity are twice as likely to be hospitalized if tested positive for COVID-19. And this is not all. Childhood obesity is expected to increase by 60% over the next decade, reaching 250 million by 2030. This underscores the importance that obesity shall play in the lives of people, not only in developed world, but also in developing country like India. It is not only in Indian urban villages or in metropolitan cities, it shall be in rural areas as well. So obesity is a real problem, and non-communicable diseases and obesity cannot be separated, even if one tries to separate these matters. So it's an area where everybody needs to work together. And on this occasion, we have invited one illustrious professional surgeon, very well known from Indraprastha Apollo Hospital, New Delhi. And he is an icon in his own right. Dr. Arun Prasad, FRCS, FRCSE, FACS, MS from my alma mater, that is Maulana Azad Medical College, MBBS from AFMC, surgical gastroenterologist, bariatric and robotic surgery, and academic advisor and clinical tutor in the Department of Surgery at the Indraprastha Apollo Hospitals, New Delhi. And we have invited him to talk on current concepts in obesity management on the special day today, that is the World Obesity Day. Dr. Prasad has more than 35 years of experience as a surgeon, and he makes him one of the most experienced surgeons in India and globally, doing laparoscopy since 1990, advanced laparoscopy since 1997, single incision laparoscopy since 2010, bariatric surgery since 2004, and robotic surgery since 2012, and pediatric endoscopy since 2018. He's a medical graduate from the prestigious Armed Forces Medical College, Pune. He did his master's in surgery from Maulana Azad Medical College, New Delhi in 1988, and went to UK for higher surgical training in gastrointestinal surgery. Thereafter, doing FRCS in 1990, he worked as Charing Cross Medical School, London, and associated hospitals. Laparoscopic surgery was started by his team at that hospital. He has won many awards and he has many achievements to credit. A few of them are award by the Health Minister of Delhi for thoracoscopic work, award by Health Minister of India for pediatric work, orations of Association of Surgeons of India, Delhi and Andhra Pradesh, and invited keynote speaker at Ghent, Belgium for robotic surgery, award for robotic pediatric surgery at Walloland, Spain, faculty at multiple international conferences of laparoscopic surgery, robotic surgery, and pediatric surgery, London, Montreal, Vienna, Paris, Naples, Milan, Tokyo, Hong Kong, Singapore, Germany, Spain, and China, and many others. Live transmission of surgery to national and international conferences showing robotic and pediatric surgery, organizer of fellowship courses in pediatric surgery at Mumbai, Philippines, Duke University, USA, on behalf of IITs of UK. And I've not finished off. But for today, I think this should be a good ground for such a renowned surgeon to speak on the World Obesity Day. And the topic that he's going to speak with us is on current concepts in obesity management. So here we are for you, Dr. Arun Prasad.
Sir, our president, Dr. Gajendra ji also joined, sir. So,
Right. So we will take him up at the end of the session. Right. Dr. Arun Prasad, welcome to speak.
Thank you. Thank you for those kind words and generous introduction. And it's a great honor to be part of this forum and this platform. And congratulations to all the organizers for doing this wonderful educational job for all the medical community. And without wasting much time, I'll proceed with my topic for today. I'll start with sharing of my screen on the World Obesity Day today, as you have just mentioned. So when we talk about obesity these days, especially when we talk in Indian scenario, we are looking at diabetes and obesity, a double whammy which has hit us over the last couple of decades. And now we call this as diabesity. I'll try and make my presentation simple. So India has the second highest number of diabetes as of 2019. So this is not such a sweet news as the slide says. And we are quite rapidly increasing in number, and probably we will overtake China in the near future. Now, diabetes in India, you can see how the numbers are increasing. And in 2045, we are expected to be, having 134 million people with diabetes. And in the bottom right, if you see 1 million diabetes related deaths took place in 2019. And the national prevalence of diabetes is 8.9%, which means about 1 in 10 people are diabetic. So if we have an audience today of 100 people, probably 10 out of the 100 audience today may be diabetic. And this is the Lancet study, which shows state-wise prevalence and increase in overweight in adults from 1990 to 2016. Just see the remarkable change which has taken place on this picture there. Number of deaths due to diabetes, 1.1 in million. So that is quite a high, and perhaps one of the highest is in India. So diabetes is the India's bitter truth, and there is 128% growth of diabetics in between 1990 and 2013. And this is more in men compared to women. The diabetes is also an important cause of other linked diseases like eye-related, skin-related, heart problem, kidney problem. And 90% of diabetes cases in India are due to change in lifestyle, obesity, and family history, as you see on the right bottom side of the slide. It is an economic burden, and we are looking at an expense of 10,000 rupees per year, or in rural areas about 6,000. And the annual cost of diabetes in India is about 34,650 crore, which includes medicine, consultation, hospital charges. It does not include treatment for diabetes linked diseases. So if you include diabetes linked kidney and heart diseases leading to heart surgery and kidney transplant, then this number is going to be even bigger than this. And gender wise, as I said, male, there is a higher incidence of diabetes. So this burden, as per a recent survey, India has 75 million obese population, with 50 million are morbidly obese, and India has 80 million type 2 diabetics, and 25% of them are morbidly obese. So this shows how morbid obesity and diabetes go hand in hand. Obesity results in 1.5% of our GDP drain and $250 million of additional cost for treatment for complications arising out of obesity and type 2 diabetes. Now, India has 9.5% of its adolescent population as overweight and 5% as obese. Now, this last line is the most serious thing, because when this population gets converted to adult morbid obese in future and causes problems like heart disease, is going to be quite a disaster. And it's also said that 25% of the obese children are going to develop diabetes. That's a huge number too. Now, this is a slide from our physiology books. I don't think I need to talk much about this to doctors. Basically, this shows how glucose stimulates insulin secretion, and insulin is what makes the glucose uptake in the muscle. Also, insulin opposes hepatic breakdown of glycogen and breakdown of fat. In other words, if the insulin level is to go up because of insulin resistance in the body, that is going to prevent fat lipolysis, and this is what can cause obesity, fatty liver, and other such problems. So diabetes, this is a vicious cycle. Obesity leads to insulin resistance. Insulin resistance leads to high blood sugar. High blood sugar leads to high insulin levels, and high insulin level leads to obesity. So this vicious cycle goes on, and it is quite a challenge to the medical profession. A small couple of slides on incretin. Incretin stands for intestinal secretion of insulin. So if I will need a little attention and concentration from the attendees here for the next two slides. So please look at this slide, and the incretin effect demonstrates the response of oral versus IV glucose. So if you look at this slide, the green line is oral glucose, and the red line is IV glucose. So the left side of the slide, if you see, this is showing how when we give somebody oral glucose, the blood glucose level, venous glucose level is going to go up and then come down. If you give them IV glucose, again, the blood sugar level is going to go up and come down. This is what is showing on the left side of the slide. Now, if we move to the right side of the slide, this is showing us the C-peptide level. C-peptide level basically reflects the insulin level in the body. So what you see here on the right side, that when we give someone oral glucose, you can see how the green line goes up, which means the oral glucose leads to an increase in the insulin levels, while the IV glucose does not lead to an increase in insulin level that much. So you can see this gap. So on the left side, if you see whether we give oral or IV glucose, the blood glucose level is going to rise. But when you see on the right, the insulin level rises with oral glucose, but not with IV glucose. This means there is something in the gut which is causing this, because the oral glucose is causing rise of insulin. So this gray area which you see there is known as the incretin effect. And this incretin effect is very crucial, because this is what has revolutionized both the medical and surgical management of diabetes and obesity in the last few years. At the end of the session, if anyone wants to ask any question about this slide, I'll be happy to answer. So let's look at a diabetic patient. So on the left, you can see a control subject, which is similar to the last slide, where the insulin level goes up and down by oral, but it does not go up that much by IV, which is the red. But if you see on the right side, what you will find is that the oral glucose is unable to raise the insulin level. This means that there is something wrong in the GIT, something wrong in the body system, that the oral glucose is unable to raise the insulin level. So the incretin effect is reduced in patients with type 2 diabetes. So how do we manage? Management includes weight control, increased protein intake, reduction in our carbohydrate intake, isometric weight exercises, cardio exercises, medications, and metabolic surgery. So the first 5 of these is a separate talk by me, which is on weight management. Hopefully I'll speak to you some other day on that. Today, I'll stick to the bottom 2 points, which are medications and metabolic surgery. So to understand that, we are talking about enterohormones, which are GLP-1, glucagon-like peptide. Now, most doctors would have heard a lot about GLP-1 and less about the other hormones, but all these hormones are enterohormones, which are important for the homeostasis of glucose metabolism and insulin in the body. So GLP-1 effects in humans. what happens? So GLP-1 is secreted upon ingestion of the food from the intestine. So the GLP-1 basically increases the beta cell response and it reduces the beta cell workload. So it increases the insulin secretion while it reduces appetite, postprandial glucagon secretion, etc. So as to balance the metabolism which had got imbalanced. So talking about the medications, we have a few US FDA approved anti-obesity drugs, starting with Orlistat. People have heard a lot about Orlistat. Orlistat affects the fat absorption. Unfortunately, Orlistat has not been that effective in the Indian population for the simple reason that we are not a fat-eating obese society. Our obese society is because of high intake of carbohydrate and low intake of proteins. So trying to reduce fat absorption does not help that much. Then there are other drugs which are there like lorcaserin, and then there is a combination of phentermine, propionate, and finally liraglutide, which is Saxenda, and that is the one which is the GLP analog. So when we talk about Saxenda or liraglutide, this liraglutide comes as an injection, 3 milligram injection. Saxenda currently is not available in India, but what is available is what you can see on the right side, which is Victoza, which is for diabetes management. But Victoza, when given in dosage of 3 milligrams injection per day, also has a good effect on weight loss. The newer version of Victoza, which is coming soon, is what is known as semaglutide, which is a 2.4 milligram once a week injection. Right now, hopefully soon, we are also going to come up with the semaglutide oral medications. Currently, we are doing a trial. I'm also part of that trial, and initial results are pretty good. So hopefully we will see some new things in the market by my next talk, by the next obesity day. Coming to metabolic surgery, there have been metabolic innovations, and 2013, this was one of the top innovations, which is metabolic surgery, whereby we were able to cause remission in diabetes after metabolic surgery. Now, this was quite a landmark because this showed how obesity is a gut-related and diabetes both gut-related disease, which can be manipulated by surgery. So we have the options of gastric balloon, which is bariatric endoscopy. And in gastric balloon, basically, we have a balloon that goes in by an endoscope. We also have swallowable balloons these days. The balloon is introduced via an upper GI endoscopy after checking the entire stomach. You can see the stomach is being checked. And the gastric balloon is put inside. On the right, you see what is known as endoscopic sleeve gastroplasty. Here you can see me do this procedure whereby we put in an endoscope and basically stitch the edges of stomach together to reduce the stomach, very similar to what you do in a sleeve gastrectomy surgery. Sleeve gastrectomy, as most people would have heard, is one of the commonest bariatric operations which we do in India and worldwide. And you can see how this is like a sewing machine picking up the stomach mucosa, and this is a trans-gastric stitch which is applied to reduce the size of stomach. We also have technology for us in such kind of patients who are weighing over 250 kgs. These are the super obese patients where we do robotic surgery. So the surgery can be done by laparoscopy or by robotic. The video I'm showing you is of robotic surgery. Here I sit on this console and I'm able to control the instruments and do the surgery using robotic arms. And this is a very precise surgery. It has led to a reduction in bleeding and leakages and other complications. Pain is less, that's the patient being shifted. And 6 hours after surgery, he is able to walk to the toilet. He reduced almost half his weight in 1 year. The blood sugar became normal, so did the blood pressure, and the OSA disappeared. He sent me a picture. This is his jeans, which he was wearing. Now you can see he's wearing the same jeans after 1 year. So he sent us this picture. Then when he came to our OPD, by then he had to buy a new pair of jeans. That's him on the extreme right. Another patient. So these are a few patients. This one is a model now. You can see here on the right. So metabolic surgery, what do? We manipulate normal organ systems to achieve alteration in physiology, resulting in resolution of disease process and weight loss. So this is manipulation of normal organ systems. There is a foregut theory which says how the duodenal part of the intestine produces anti-incretins, and bypassing this leads to improvement. Similarly, there's a hindgut theory which says how after a bypass, the food reaches the distal bowel quickly and increases the production of the GLP-1 naturally in the body. So these two theories is what is prevalent to explain how the GLP-1 level goes up, the insulin resistance goes down, and patients become better from diabetes as well as weight point of view. So it's basically due to early delivery of food to the distal ileum and bypass of the duodenal and proximum jejunum. This is the pathophysiology of diabetes surgery or a gastrointestinal bypass. There are various other mechanisms. I'll not go through these. This is a slide for our surgical presentation. There have been studies, there is evidence in literature on bariatric surgery versus intensive medical therapy in obese patients with diabetes. The 5-year results showed the effect of both surgical procedure to normalize glucose level did, however, diminish over time, and some late complications were noted with surgery. However, rate of achieving and maintaining HbA1c level 6% or less at 5 years were significantly higher with gastric bypass and sleeve gastrectomy than with intensive medical therapy alone. This is a conclusion of the study, which shows how in severely obese patients with type 2 diabetes, bariatric surgery resulted in better glucose control than medical therapy. Preoperative BMI weight loss did not predict the improvement in hyperglycemia after these procedures. In other words, the procedure had good effect regardless of what the preoperative BMI was and regardless of how much the weight loss was. Surgical versus conventional. Again, the cost of treatment over time is actually cheaper with surgery. Both the RCD showed how the surgical treatment is giving us better results than just managing medically. We also have the hybrid option where we can do surgical and medical management. For example, the endoscopic bariatrics can be combined with medical management, and we can have various combinations. So how can we predict? Rather, why should we predict? We should select the group that will benefit, avoid patients who will not benefit, predict the degree of benefit, predict the duration of benefit, predict the chances of relapse. And this is what is important for us. So the best results of surgery for diabetes, we found the results in male sex, those who are a younger age. The diabetes duration is short, that is less than 5 years. High C-peptide levels, which is more than 3.5, this means there is good reserve. No GAD antibodies, patient not on insulin and only on metformin. So these are the patients who benefit most. Now, we've also had a COVID's parting gift where experts say many patients with no history of diabetes are reporting unusually high sugar levels with COVID-19 infection because COVID may attack insulin producing beta cells. In patients with diabetes, may be triggered by severe physical and mental stress exerted by the infection. Some patients may have had undetected diabetes. So people are advised to watch uncontrolled eating, sedentary lifestyle, and stress due to COVID. So to conclude, I would like to say diabetes with obesity is a lethal combination. We should be looking at preventing this. Non-medical management is always the best management, that is prevention. Medical management, we've had a lot of research is going on. Metabolic surgery is another area which has to be considered when we are treating people with obesity and especially diabetes. With that, I come to the end of my presentation. Thank you everyone for listening. If there are any questions, I'll be happy to answer. Let me see in the chat box if there are any questions.
In the Q&A box, there is one question from Dr. Damodar Lele. And it says, if a person starts eating the quantity of food which he would eat in case he undergoes bariatric surgery, will he have same benefits without bariatric surgery, since surgery achieves reduction in volume or the size of stomach and he eats less?
Right. So there are two types of surgery we are looking at. We have a sleeve gastrectomy where the size of the stomach has been reduced. However, in that too, what I was talking about earlier regarding the food moving down faster through the duodenum and entering the terminal ileum, that also takes place because of the lowered capacity, and there is an increase in the GLP-1 levels. So the patient's appetite would have reduced because of the reduction in the stomach size. The satiety is much faster. So these patients, yes, they would be eating less anyway, but because of the hormonal manipulation that has taken place because of the GLP-1, the weight loss and the anti-diabetic effect will persist. In patients who have had gastric bypass surgery, these patients are able to eat almost the same as they were eating before surgery, and they will continue to lose weight and have good benefit from diabetes because of the increase in the GLP-1 levels and the reduction in the anti-incretins. So yes, the bypass patients can eat exactly the same food they were eating before surgery and continue to lose weight and have benefit in the diabetes. Having said that, we are not suggesting the surgery as a magic treatment to anyone. As you know, all surgeries have their own risks and complications, and surgery should always be considered as the last resort after all lifestyle modifications have failed.
That's wonderful, Dr. Arun. At this juncture, I would like to bring in the president of the Association of Environmental and Occupational Health, Delhi, Dr. Gajendra Kumar, and he has raised his hand as well. So I request Dr. Gajendra Kumar to make his comments and any questions he would like to ask.
First of all, I compliment Dr. Arun Prasad for such a wonderful presentation on this subject.
Thank you.
You have made so many things clear, very clear to us, and really many things we were not really aware about it. Now I got 2-3 questions with you. My first question is, unfortunately in our country, every time a diabetic or a patient with morbid obesity, he is not getting feeling some improvement with the medication, instead of going for surgical or a better interventions, they straight away switch over to the Ayurveda. And my observation in the hospital, I worked as a chief consultant in Northern Railway Central Hospital in Connaught Place, that many of our patients with end-stage renal disease are those are on purely Ayurvedic medications, and their diabetes was not controlled. So I would like to have your comments on this, number one.
Right.
Then I'll ask subsequent questions.
Right. So this is, a failure from our medical profession, that we have not been able to educate the public of the benefits of lifestyle changes, diet, exercise, medical treatment, and surgical treatment their benefits, the benefit and risk ratio. It's basically our failure that we have not been able to educate the public. And it's important for us to start right from childhood, right from the school, to teach children on the benefits of having normal weight. Because as I mentioned in the earlier part of my presentation, 25% of the children who are obese are going to get diabetes. And with Ayurvedic treatment, see, we really don't know sometimes who is the Ayurvedic doctor and their credentials. Sometimes they could be giving something toxic, which has actually led to the damage of the kidney. So there are, like in all professions, all over the body, there are good people, there are bad people. So we don't know who they go to. And there is, without any quality control or without any good knowledge about what is being given, supposing somebody is given a pudiya with some powder in it, we don't know what it is there. Maybe there is some thyroxine there, or maybe there is some our medications or something toxic. So it is quite dangerous. I agree with you.
My next question is regarding this liraglutide injections. See, how many percentage of obese patients in your practice you are putting them on this liraglutide?
Right.
Because in our hospital, almost only diabetics are on this.
Yes. So liraglutide is currently the Saxenda, which is the one for weight loss, the 3 milligram, that is not available in the market.
Okay.
So sometimes we are putting on these patients, preparing for surgery, or some kind of a temporary, somebody's being prepared for, say, a kidney transplant where you need certain amount of weight loss. Patients who are not are gaining weight for some reason. So there we start with 1.2, increase it to 1.8, and then increase it to 3 milligram gradually. When you say 3 milligram, they'll end up taking 2 injections, 1.2 and a 1.8. And this can lead to about 10% of weight loss or 15%, but this is reversible. Once they stop taking it, unless they have modified their lifestyle or undergone some procedure, they will regain the weight.
Thank you. Thank you, Doctor.
So, Dr. Arun, there is another question from Dr. Vinod Kumar Mishra from Korba. He wants to ask the role of keto diets.
Right. So keto diet is something that has been quite a fad, and it has worked for many people. I also know people where this keto diet has worked, and the problem with this is maintenance. So how long you maintain your weight and how long you maintain your diet is very crucial. And we have statistics which says that people who are, say, morbidly obese, 95% of them are going to regain their weight, because it's very difficult for them to fight the changes which have taken place with regards to what I was showing you, the insulin resistance and other things. People who are borderline overweight, like most of us are, it will work very nicely.
Well, and there's another question from Dr. Akanksha Srivastav. Do we have any strong data stating lowering the CV risk and reducing, and also on microalbuminuria?
Improvement?
Yes.
Yes. So there have been publications on these kind of improvements which has taken place, and as one cannot reverse diabetic complications. So if somebody's had a renal damage, one cannot reduce, but it has been shown by data that the progress of the complications, the progress of the renal damage has been reduced. And there is a very controversial thing which was there few years ago. One of our esteemed ministers had undergone bariatric surgery, and what we had noticed was that it actually, the bariatric surgery had an effect on the renal complication of the diabetes, and it actually prolonged the life and prolonged the situation. So obviously, we cannot reverse it. The person eventually did have a renal transplant, but I think 6 or 7 years were covered with the benefits of the surgery.
So it's de facto palliative.
Sorry?
It is de facto palliative in nature.
Palliative is a a different word which we usually use for cancer and other things. But what we can say is that it blunts the curve of complications. But in people who, as I mentioned in my criteria, who are early diabetics, who have got good GLP-1 reserves and who have undergone treatment fairly well in time, it has led to complete remission. Diabetes completely disappears. The HbA1c, which was 9-10, has come down to 5.5. I've got follow-up patients of over 10 years where they have never touched any diabetic medications for last 10 years after their surgery.
That's true. It's so rewarding, and the person gets committed to actually maintaining his lifestyle. The surgery is helpful in that way. His attitude towards obesity changes.
Sure. So this is what I was stressing on my slide, that we need to identify the people who are going to gain. So if there are 100 people who are there, all 100 are not going to benefit. But if we can pick up the 20 or 25 who are going to benefit and offer surgery only to those people, then that is where the beauty lies.
True. Question have come from Dr. Bhudev Sen Gupta. The first question, he says, what is the current BMI marker for Indian men and women to declare them obese?
Okay. See, the overweight starts from 22.5 BMI, but obese is coming at 27.5 BMI. And if somebody wants to know the surgical indication, so 32.5 with medical comorbidities is an indication, and 37.5 as a standalone BMI is an indication for surgery.
That's very accurate, actually. But what is the current waist circumference marker to call obese for Indian male and female? That is another question that he has asked.
Right. So here we have not just waist, it's a waist to height ratio. So if it is, less than 0.4, sorry, more than 0.4 in females and more than 0.48, or maybe you can say 0.5 in male, then that becomes that you are prone to metabolic syndrome. And metabolic syndrome, as I think everyone knows, is how we have got glucose metabolism intolerance, hyperlipidemia, and hypertension. So metabolic syndrome has its own definition, and that is something which is quite prevalent in Southeast Asia.
True. Another question that is there any caste, race, religion variation observed in obesity trends in India?
No, there is no such relationship with this. But what happens is that there is a difference in the diet in all these people. So, in certain religions, you will have more people eating non-vegetarian food. So they would have a higher protein or a muscle mass. So they respond to our surgery differently than to a pure vegetarian who has been having more higher intake of carbohydrate and they have less muscle mass. Similarly, again, caste in India also defines, the socioeconomic status. So somebody with a lower socioeconomic status, the chances of them having sarcopenic obesity. When I say sarcopenic obesity, this means that there is very little muscle mass, and because of carbohydrates and because of fluid in the body and edema, so the patient is overweight. So you'll see people with thin muscles but a big tummy. So that kind of a difference is there. So it's more related to socioeconomic status and eating habits rather than caste or religion.
Very true. Related question is, one expert has recommended 2 windows to follow in 24 hours, 12 hours eating window and 12-hour fasting window. How far it is justified?
Okay. Now, there have been a lot of, studies and results, etc. But this kind of a window thing doesn't work for too long. And what we feel is that you need to keep the body full, because when the blood sugar level falls, if you keep yourself fasting for too long, then the brain is going to demand carbohydrate and you will immediately want to take carbohydrates. So a hungry person, it's literally impossible to make a hungry person eat chicken, but the hungry person would probably want to eat fried rice or something which has got more carbohydrates. So too long a fasting is not a good idea. What should be done is to keep the stomach full with healthy diet. My presentation on diet is a totally different presentation where we talk about high glycemic and low glycemic index food. So you can go on the internet, check the high glycemic index of any food, and food with low glycemic index, good fiber, one should be eating more frequently. So I would say that after sunset, have more fruit, salad, uncooked food, keep your stomach full, because if you don't keep your stomach full, the brain is going to take over finally and force you to open the fridge at midnight and take carbohydrate and spoil the entire day's plan of yours.
Yeah. In fact, a spin-off from this question is another question. Will you recommend 1 day fasting in a week for religious ground, which will be also helpful to combat obesity?
See, it has been shown to have its benefits, this 1 day fasting a week, and it has been going on for traditions. And as we know that our traditions which have been there have all had a good scientific basis. As the years have gone by, many traditions which people used to laugh about, finally we have found good scientific evidence. So I would not say anything against this fasting habit. This fasting once a week, some studies have shown that yes, it has good effect on the liver homeostasis and the glycogen metabolism. So please carry on. There has not been much study in the Western world on this fasting. And as you know, we are a lot dependent upon the data which comes to us from the West. So if we were to say have a study to find out the benefits of this 1 day fasting, I'm sure we will find benefits. But currently, I'm not in a position, I'm not qualified to either say yes, it's good or say it's bad. But I have a feeling that I'm sure there must be something good. That is why for generations, this is something which our forefathers have advocated.
True. We have in the panel here Dr. Sandeep Sharma, who is a board member of the International Commission on Occupational Health. Dr. Sandeep Sharma has raised his hand. He may have some comments or questions.
Yeah, thank you, Dr. Arun Prasad sir, and thanks Dr. Rajiv Kumar Jain sir for giving this opportunity. Sir, first of all, let me thank you for raising this important issue on this World Diabetic Day. Now, the question which
World
was
Obesity Day.
World Obesity Day, we were talking diabetes, so I just it came out. So on World Obesity Day, this topic is very relevant. And sir, what the this earlier question was about the window period. So this window period actually is important because it takes care of the insulin resistance. So what people are advocating now is going for intermittent fasting. So this intermittent fasting, it reduces the insulin resistance, because if you keep on eating the whole day, then the insulin levels will fluctuate in your system, and accordingly insulin resistance will occur. And as you rightly said, sir, the glycogen breakage and the lipolysis, fat lipolysis, it is hampered by insulin resistance. So intermittent fasting and this window period of eating, this is the best way to reduce the insulin resistance and to increase the lipolysis. Means whatever fat is stored in various areas of your body, so that can be easily transported back and taken into the system for energy production. So
that's I fully agree with you. My only word of caution is that after your intermittent fasting, when the fasting is over, please eat healthy food. So don't okay, now my intermittent fasting is over, let me have a pizza or a burger should not be the aim. After your intermittent fasting is over, you break the fast with something with low glycemic food, good protein, a healthy food, fruit and salad. And that is what is very important, because if you don't do that, the entire exercise of this intermittent fasting would have been wasted.
Yeah. And so the other plans which were earlier, they were very important, like keto diets or uni component diets, like fat-free diets or low sugar diets. So all these diets, they were basically focused on eating only. So ultimately, your health is your mind, body, and soul. You have to train your mind eating is also a mindful habit. It
See,
is,
what we have heard from childhood, which is balanced diet,
yeah,
always is the best diet. So
yeah.
you should have little bit of everything. Keep a balanced diet. Don't spoil the balance, because if you spoil the balance, your balance is going to get spoiled.
Yeah. So sir, we being occupational physicians and we are all practicing in industries. I am in Indian Oil Corporation. So we all promote preventive health rather than curative. So, but still, if someone requires, if he is in morbid obesity or he requires, he's not being cured by the preventive measures, then he needs to be taken care of by medicines or bariatric surgery.
Yeah, see, bariatric surgery is done when the obesity becomes a threat to life.
Yeah.
It is not done to make you into a model. It
Yes.
is done to increase your lifespan. It is done to improve, to help you medically. It should not be taken lightly. We are here to offer bariatric surgery. The results are very good, but it should be considered as the last resort after everything has failed. It is not the shortcut.
Right, sir. So it was just my opinion. So I thought, yeah, I should discuss.
I agree, fully agree with you.
Right, sir. Thank you very much.
So, Dr. Arun, Dr. BP Singh has asked another question. Is there any relationship between obesity and gut flora?
Yes, obesity and gut flora, there is a relationship, and a lot of trials are going on, because the gut microbiota which is there, it affects our GLP-1 and various gut hormone levels. So I'll give a small example, that if you take the stools, fecal matter from a thin person and make it into an enema and give it to an obese person, the obese person will lose weight, and even his GLP-1 levels, his insulin resistance is going to go down, because in his gut, these gut flora and microbiota are missing, which is there in the other person. Now, how to create this gut flora is something which we still don't have the answer to. After bariatric surgery, the gut flora changes, because then patients, now this is in the animal models. So mice and guinea pigs who have undergone gastric bypass, when you check their gut flora, it is different from what it used to be before. And this is partly related to the bilioenteric circulation of bile also. So the bile acid level goes up. And there was one slide which I did not go through, the one with the circle and arrows. That slide is what I was explaining this. So this is a big science. We can go into all sorts of areas, and maybe if, I can talk about diet, what is the best exercise, to what is the molecular level and what is the basis, maybe on another talk.
In fact, that's unique about you. I very, calling you as a mere surgeon would not be appropriate. Your attitude, your understanding, and your way to look at things is so global. This 360-degree view of the problem of not only obesity but metabolism at large, and it's a treat to watch you speaking, because normally surgeons would restrict to surgery. They would not address the entire issue comprehensively.
No,
Great
this is.
to hear.
I'm here on an anti-obesity campaign, and surgery is a small part of it.
Great, wonderful to have a person like you, and that too in the Prasad Apollo hospitals. Dr. Romana Wani has asked, what is the weight loss plateau?
Okay, so the weight loss after bariatric surgery, I assume, is what he's saying. And generally, we see a weight loss about 4 to 5 kgs a month. Over a period of 9 months to 1 year, this weight loss is going to plateau down in most bariatric surgery. When we talk about endoscopic bariatric, it is a weight loss about 1 to 2 kgs a month, and that plateaus again between 6 to 9 months.
Yes. I'm noticing the World Obesity Day website. Today, they released a press release where they're calling for global action plan on obesity at the World Health Assembly in May 2022, while releasing the World Obesity Atlas. So what are your views on this?
I am actually not aware of that. So I'll have to pass that question. I have not read this.
Right. I posted the link if you would like to have a look at the World Obesity at this. This is an important,
Wonderful.
resource where all the people are concerned with obesity are got together globally, and this campaign and this, in fact, World Obesity Day is held under their IGs, and it's wonderful to look at how comprehensively 20 countries, including India, is occurring in the top obese countries in the world.
True.
And how India, even though we thought highest malnourished population, yet we are also in the top 20 obese countries in the world.
Yeah, so
That's a paradox.
So this is the double whammy which is there. And if we see out of 100, 45% of our population are malnourished, 20% are obese, and only 35% of the people are of normal weight, which is very unfortunate. In global ranking, we are number 3 with obesity, but in childhood obesity, we are actually number 1, and we have beaten US in that, and we are second only to China. And the childhood obesity is something that is the most worrying, because all these children, if they grow up as obese, it's going to be a big problem for our country.
True. That is the bigger challenge that we have in the years to come. And it, as the press release today is also predicting, it is going to be a kind of endemic and pandemic. With non-communicable disease, it is going to be a double whammy. And third complication is our incomes are low. So we, in fact, will suffer doubly, because we will not be able to afford appropriate nutrition. So the suffering due to high frequency of diabetes and NCDs and obesity together will result in a very tricky situation where we may not be having the resources to tackle obesity at a larger level.
Yeah, so that's why prevention at school level is most crucial today.
Yes. Another issue which I would like your comments on, if you see the labeling in India and US and European countries on the food products is different. The front of package labeling, how would it contribute to controlling obesity in a situation like India?
See, I think that is just a shortcut which people are taking. It's like, in the cigarette packet, you write cigarette smoking is injurious to health. That really is not going to prevent anybody from smoking. A different presentation of mine, which I can do at a later date, shows about these,
Yes.
A video of an ad which is there, which was being shown in last year IPL. And there it shows, I think, Karishma Kapoor or somebody who's being shown as a very good mother, how she's, making these packet food, some mac something, the various fries, etc. That by end of that 1 minute ad, you will start feeling like eating them. So, the fantastic advertisement agency, which is doing a great job for what it is being paid for. But, these ads, all these are actually unhealthy, because, it also is stereotyping how a good mother is defined as somebody who makes French fries for the kid.
Very true. It is like heritage drink companies sponsoring the biggest sporting events in the world.
Absolutely.
And that kind of inherent connection between physical activity and drinking non-healthy drinks, so to say, without naming any company for that matter.
Of course.
True. The relationship between diabetes, hypertension, cancer, and liver disease seems to be becoming ubiquitous. It's becoming a thing which requires a larger policy level action. You've seen a whole life cycle of bariatric surgery in India through different approaches. Newer techniques have come up. So what would be your take on what the government of India should do, and what the corporate sector should do, and what the community leaders should do?
See, promoting healthy diet, educating people about what is a healthy diet, promoting exercises, every colony should have a park or place where, children can play. There could be, places of exercise. This is something actually I've seen some changes happening, because 10-15 years ago, when my children were very small, none of the parks they were allowed to play, because people used to go there for walking. They were told that phool kharab ho jayenge, ghas kharab ho jayenge. Now that attitude has changed. Now many parks we can see actually park gyms where you can exercise and play. So some attitudes have changed, and it has to be a change in attitude towards diet, where people get to know what is healthy diet, what is unhealthy diet. And if you start from the children level, a child who's taught, they are going to go home and make sure that their parents follow that kind of a diet, because the entire household has to follow a diet for it to become healthy. The common joke which everybody hears about, that in my family, my obesity runs in my family, then the other person says, no, actually nobody runs in the family, so that's why it is obese. So that's a common joke which everyone has heard. So
True.
it has to be a
The
change of attitude, and the government has tremendous responsibility. If you start the educating campaign in movie halls, televisions, various things, just back of the mind, if people start getting to see the effects and the ill effects, the benefits of being healthy, it would be the right way forward.
True. I fully agree with your views. In the last, we are almost inching towards 1 hour of this talk conversation, World Obesity Day. I would like your views on the stigma attached with obesity. People who are obese are stigmatized, and one needs to tackle this issue as well. So what are your ideas on tackling stigma for obese people, against obese people?
Yes. So the stigma, it is going to take a lot of time. And again, a lot of education has to be there. And people have to be made aware. Because what happens naturally, even if someone is not biased, naturally, if you take two pictures of two people, say a child or someone who's not even biased, they will find the looks of the non-obese better or more appealing than the looks of the obese. So this is something that is also part of human nature. But we have to, counter. There are many things one would like to do. I might like to murder somebody, but that's not what I'm doing. So, that kind of an education and awareness has to be created in the mind of people. And again, it has to be a complete overall package. For example, a child who's there in the school, he is obese. He goes to play. He's not able to take a run, or he gets run out. Other children will say, "Arey, because he's so fat, he got run out." So then he's going to be stigmatized that because he's fat, he's not able to play well. The team has lost. So what will happen? He will stop playing. He stops playing, he will get even more obese. It will become a vicious cycle. So this vicious cycle has to be broken, and this can only be broken by bringing a lot of awareness and education. And this is, I can go endless on this. Children, when they become teenager, that's the time for them to play. But what do? The moment they become teenager, instead of playing in the evening, we put them into coaching class, because they have to go for entrance exams after 2 years when they reach the age of 16 or 17. They come to class 12, even the weekends are gone. Weekend special tuition class, extra classes. So naturally, these kids, if you see kids who are at the level of entry of medical colleges and engineering colleges, most of them you'll find are obese.
Very true. So time has come and time runs fast. And when you speak, time runs faster, because we want to listen to you more. And it's a treat to discuss issues related to obesity in a very comprehensive, global manner. I am really grateful for the time you've given, for the comprehensive scholarly presentation that you made on obesity, current concepts management. And last but not the least, I would be really grateful to all the panelists and the audience who have asked their questions, who have made their points, and there are a number of chat comments which are appreciating the way you have deliberated on the issue and the unique view that you have. I would like to inform you that this recording of this webinar of 1 hour will be uploaded on the YouTube channel. There is a dedicated YouTube channel which is known as Enoch ENOCH DigiConnect webinar platform. That recording is very well patronized by people across the world. And if somebody has missed, they can always go there and see your slides as well as your comments and response to questions. And thereby, they will further be able to spread the message that you are trying to address on the World Obesity Day. In the end, we would like to share a video which is summarizing a 1 minute video which summarizes the World Obesity Atlas 2022, the summary of in 1 minute. So I'm really grateful. Thank you so much for sparing your, and the video is here playing now. Just 1 minute, 15 seconds.
Thank you.
This is the stark reality of obesity in the world. 30 least prepared countries are all lower, middle, and low income countries, including India. 160 million lost years of healthy life due to obesity. More than 20% of all lost years of healthy life caused by preventable. We need to act now to improve how we prevent, treat, and manage obesity. And the need for global action plan on obesity. I've given the link in the chat box as well, and one can go to worldobesityday.org to get to know more. Thank you so much for sparing your time. Dr. Arun Prasad, we are really grateful, and we are grateful for the audience as well here and the YouTube channel. Thank you so much. Thank you.
Thank you. Thank you all.
Thank you all. Thank you also.